Good day and welcome. We're here to talk about some of the exciting news coming out of the San Antonio Breast Cancer Symposium and also some ESMO updates and even some updates from last year's ASCO. I'm here with Dr. Tweed. You want to introduce yourself to our audience, please?
Sure. I'm Carol Tweed. I'm a breast specialized medical oncologist in Annapolis, Maryland. It's nice to be here.
Fantastic. Welcome. Look forward to our discussion. So in terms of first-line HER2 positive metastatic disease, we've been doing the same thing for a long time, for more than a decade.
Yeah.
The Cleopatra regimen. What's your experience been like with that? And are you satisfied with that? Or is it finally time to see the death of Cleopatra and move on to something more cutting edge?
Well, I will say, of all of the spaces where we have been comfortable, it has been this Cleopatra space. Mm-hmm. After you get a patient through the first few months of systemic chemotherapy, patients can have very long time, excellent quality of life, sure. Sometimes. And then we had some gaps to fill. We had central nervous system gaps to fill. We had improved efficacy gaps in patients who presented with heavy visceral and symptomatic burden. So definitely needed improvement, and we definitely are seeing that here. But I will say that the experience during these years with the Cleopatra regimen has allowed us to learn a few things. And one of those things is how lovely it is to preserve quality of life during a maintenance period.
Sure.
Yeah.
Of course. What was your maintenance in, let's say, the hormone receptor positive subset of HER2 positive first-line metastatic? Were you layering in, along with the dual antibodies, were you layering in endocrine therapy?
I did. I think, early on, I think perhaps not, because the trial originally, did not do that. But ultimately, for the majority of the time, yes.
So last year at San Antonio, we saw a presentation of the Patina trial, which was not only an endocrine therapy and dual antibody maintenance, but also layering in a CDK4/6 inhibitor. What are your thoughts about that?
Well, I actually was incredibly enthusiastic about it.
Yeah.
I thought that this was a landmark moment for us, and a resurgence of Palbo. However, still not published, still not in guidelines.
Right.
However, I will say, with the benefits seen in the trial, which was a substantial prolongation of progression-free survival, I have used that regimen.
You have?
I have. And
interesting.
Yeah. So the drug is incredibly well tolerated, palbociclib. So it's quality of life not really impaired. There's certainly a cost issue.
Right. And in your jurisdiction, no issues with payer coverage?
No, it's a small. It's a small N. An N less than 5. But no.
And then in 2027, palbociclib becomes generic.
Yeah.
So presumably the price will drop substantially. So that could be a refreshing new paradigm for selected patients, perhaps.
Agree.
It's really interesting. You've already been using it. That's really provocative. Now, I assume the reason we haven't seen regulatory filings and publication yet is because it was late breaking last year at San Antonio. I think they got everything in line for a late-breaking presentation like the night before the meeting or something, literally. So I think it takes a while after such a rush to get those things moving.
I think you're right. I do remember, there's a small piece of me that harkens back to the TCH versus AC to TH era where we went years before publication and at some points got quite nervous about why.
That's true.
Yeah.
Interesting. Now, we saw at this year's ASCO a presentation of a new first-line antibody-drug conjugate potentially for HER2 positive metastatic disease, specifically in the DESTINY-Breast09 study. Can you tell me about that trial? Maybe it's the trial design to start with.
Sure. So DESTINY-Breast09 randomized patients to a taxane with dual anti-HER2 antibody therapy, Trastuzumab, Pertuzumab, a la the Cleopatra regimen.
Based.
And I think a minimum of 6 cycles, important to say, because, some of us over the years have perhaps been stopping at 4 when appropriate. And compare that to Trastuzumab Deruxtecan with Pertuzumab versus Trastuzumab Deruxtecan with placebo.
Mm-hmm.
Ultimately, unlike the Cleopatra regimen, endocrine therapy was allowed when the taxane after a minimum of 6 cycles was dropped or after 6 cycles of T-DXd.
Right. And then there was a T-DXd placebo arm without the Trastuzumab. I understand there were insufficient events for that arm to be yet recorded.
We don't have the data regarding that.
And interim. So we'll wait until we get enough events to see that. I'm sure probably this year, coming year, probably 2026, we'll see that. What were the general kind of patient characteristics in DESTINY-Breast09?
I mean, these were pretty classic first-line metastatic patients. I think they had to be more than 6 months from curative intent treatment.
Right.
Otherwise, I think very representative of our real-world HER2-positive population.
Yeah, I mean, there was a slight numerical, a little more than half were steroid receptor positive.
True.
I expected in this kind of population. And then they were, chemo naive in the metastatic setting.
About a third PIK mutated, right?
About a 30% PI3 kinase mutation, and Asian predominant patient population. I think about maybe over 40% Asian population here.
Few Black women.
Unfortunately, that's the case. And then let's see if there's any other patient characteristics that I thought were important. I think that covers most of the bases. We did steroid receptor. Yeah, that's a pretty good review.
Central nervous system.
I think stable brain mets were allowed, but it was a small fraction. Maybe.
Asymptomatic is stable.
Yeah,
Yep.
I think it was only about 6% and brain mets at baseline. And then in terms of the treatment, what were the top line data? So the primary endpoint.
I mean, the primary endpoint was favored T-DXd and pertuzumab in the comparison to taxane, pertuzumab, trastuzumab. Regarding the T-DXd placebo arm, we don't know the results of yet. A prolongation in progression-free survival. And the progression-free survival in the taxane arm was much longer than that, which we saw in the Cleopatra arm, which is something to be noted. But also a substantial improvement in response rate, some increased toxicity, and the pneumonitis
I'll
route.
talk about that in just a minute. I want to spend more time on that, actually.
Yeah.
So I think the hazard ratio was 0.5 and change with 4 zeros after the decimal and the p-value. Pretty impressive, robust efficacy signal.
Yeah.
Median PFS on the experimental arm was something like 40.7 months.
13-month difference.
That's extraordinary.
Yeah.
Over a 13-month difference at the median.
Agree.
That's pretty extraordinary. We haven't seen anything like that in first-line metastatic disease, especially against such a robust regimen as the Cleopatra regimen.
Yeah.
So what are your thoughts on that? Is this going to be routine for every patient now in the first-line metastatic setting?
It's a complicated discussion, but the answer is yes, this is a very effective drug. I'm very enthusiastic about this. I think, there are a few scenarios where discussion with the patient will be important. What are those scenarios? Discussions of how much risk a patient's willing to take regarding toxicity or long-term alopecia, for example.
Sure. Yeah.
Because these patients on T-DXd were on this continuously, whereas the taxane, which could be administered with, for example, hair-preserving cold cap therapy, was ultimately dropped. So there's some of those discussions, and patient preference may come into play. Of course, we don't have survival data, and that may make patient preference along the line of tolerability. Perhaps they may be willing to sacrifice more of it if they have more information about that outcome.
So the OS was immature, only about 16% maturity.
Yeah.
So not enough events to draw any conclusions about OS yet.
Yeah.
Nevertheless, the hazard ratio was just north of 0.8 without any p-value reported as yet, since it's an exploratory endpoint at this point. But a trend, at least numerically, in the right direction. So maybe there's hope for an OS signal.
I mean,
For
sure. We have the ability now to offer metastatic breast cancer patients years on their first-line treatment, and it is just astounding.
Now, you mentioned response rate. It was 85%.
Yeah.
Have you ever seen anything like that?
No. I mean, nor again the first-line PFS. This is incredibly exciting, and when I look back to the original approval of Trastuzumab to where we are now, and it seems obvious, and these statements are made often, but it should never be lost on us what we have available right now to offer patients. And also, for the most part, this is a regimen that patients can feel very, very well on.
Yeah.
And again, I think there are a lot of complexities to the art of administration and duration of exposure and these things, which we should talk about.
Of course, yeah. And then the duration of response was really long, too. It was like 39 months. I mean, this is the highest response rate I've ever seen in HER2-positive metastatic breast cancer with any regimen.
Yeah.
So it's unprecedented.
It is, particularly when, as we all know, the HER2-positive patients can have, at times, a substantial visceral burden at the time of diagnosis.
That's one thing I wanted to mention about patient characteristics. Thanks for reminding me. It was about 70-odd% had visceral disease. So it was a visceral predominant population in this trial. Moreover, I meant to say in the patient characteristics that about half were de novo metastatic disease, which we're seeing a lot more of.
Which was, and in fact, I was so enthusiastic after the data were first available to us. I at the very same time, happened to have a very young woman with a neglected breast mass and a substantial hepatic disease burden. We had very little time to get control over this.
Wow.
And I felt like just what you said. The number of patients who were de novo, the number of patients who had heavy visceral burden, the high response rate. I was so enthusiastic about the notion of being able to use this regimen. Now, unfortunately, there was not an approval for her for that regimen. But these are the patients that, or the enthusiasm should go beyond just the amazing progression-free survival prolongation, et cetera, but that upfront ability to take somebody, salvage clinical situation, and then offer them years of disease control in life.
The other thing that I thought was really interesting is among the 85% that responded, there were, I think, about 15% that had complete clinical responses, which is almost double that of the control arm. What do you make of those complete responders? Are they some of those exceptional responders maybe that will have these years and years of durability, perhaps?
We've seen that, right? I mean, in smaller percentages of patients in other HER2 trials in the past, and we all have those patients. We have those patients who are without evidence of disease for years on anti-HER2.
Apparently cured.
Yeah, exactly, where you really start to think about we're getting into a realm of how are we going to think about duration of treatment in those patients. About saying when we fortunately have a lot more molecular diagnostics that we might be able to harness for those decisions.
That is a great idea, and I know there are study proposals to look at that issue if there's evidence of minimal residual disease in the blood or not in those exceptional responders who have complete clinical responses. Maybe that could help guide and give patients encouragement that they could take a break from their medication. Many of my patients who have these exceptional responses, they're so superstitious they don't want to stop ever, right? It's hard to talk them.
100% agree. Yeah, and they're fine. And fortunately, again, the regimens we've had available for these prolonged treatment, usually the dual antibody patients, they feel great on. And what I'm hoping is, again, we can kind of create a state, including T-DXd, where we can offer that as well to patients.
That'd be great.
Yeah.
Now, the PFS2 was also reported in this data set. It was significantly prolonged in the T-DXd plus pertuzumab arm compared to the control, and it was statistically significant. Does that mean anything to you? Are you mindful of PFS2 in these kind of data sets? Or what?
I think PFS2 is important in many trials, some more than others perhaps. But I guess the question I would ask, and I don't actually know, is what the exposure to second-line T-DXd in the Taxina was. Do you know?
I do not know the number, but I think it's a low number.
Right. Okay. So then I think that's a relevant thing when you're thinking about how much PFS2 is an important endpoint. Right. In which case, perhaps I'd like to see longer endpoints, right? So what happens when somebody gets the drug later and how I think about that? I don't know if you agree with that. I'd be curious what you think about that.
I agree. And then one wonders, PFS2 can sometimes foreshadow OS results in the future.
True.
To me, that's kind of my biggest enthusiasm about PFS2. If significant, then it gives me a sense of optimism that we might see an OS signal in the future in some studies if they're well-powered, et cetera. Now, with all this, robust efficacy and success in the clinic in terms of the therapeutic advantage we have now with ADC therapy in the first line compared to the Cleopatra-like regimens, this comes at a price, doesn't it, in terms of toxicity?
Yep.
What are some of the common toxicities that you worry about with T-DXd?
I'm really glad you're asking that, because this is where, I think it gets complicated, and I think we know that we aren't going to have data to support all of the decisions we're going to have to make once this becomes everyday use. And mostly in the first week after exposure to T-DXd, we find patients can have some fatigue, can have nausea. And that's something that when you think about that in a short term, okay. If you're thinking about that for years, that's tough. So that's one big difference, I think, between what we're used to giving and what would be now, given that the T-DXd was given continuously. And another, again, is the alopecia. You're looking somebody who has a devastating diagnosis, and there was a real gift in being able to say, hey, you may have hair loss now, you may not if you use cold cap, but you won't have it for the years that come when you're on maintenance.
Right.
And so clearly, only a minority, fortunately, have that. But when I think about quality of life, that is important for our patients. And then, of course, there's the discussion of pneumonitis. Now, having said that, I'm not sure what the real-world pneumonitis data will be if people start to consider altering the regimen for what the trial did, meaning perhaps shortening exposure to T-DXd, because we know that the median onset of pneumonitis is months, right? So if you end up using just an induction, not to say that with what the...
Mostly in the first 12 months.
Yeah.
Right.
So the question is really, what will that pneumonitis rate be if people find it appropriate to terminate the T-DXd at one point and move to maintenance? These are questions that we haven't answered.
Yeah. Now, the incidence of pneumonitis overall was about 12%.
Yeah.
That's Res 09. Unfortunately, there were 2 grade 5 events, or about 0.5%. How do you talk to patients about that risk?
So this goes back to the very early question you asked me, which is, how is this for everyone?
Right.
I think that this is a very different conversation than you and I are used to having with patients. We try to reassure them. Yes, you have an incurable diagnosis. Yes, this is devastating, but here's all the hope that we can lay out for you in this first consult, right? And in that hope, we'll say risks of therapy, but we don't have to touch upon death from therapy as a really palpable potential outcome. Now we are obligated to discuss this unlikely but potential risk. I think it's important to understand that some of this is also in the hands of the clinician. I find it very important when you talk to the patient about this, they have to understand that. But also, when I have spoken to patients about this T-DXd and about the risk of pneumonitis, which can be life-threatening, they get it, and they understand that quite often, if we do teamwork monitoring, we can catch things early. And so I find it really crucial that the patient and the family are well aware of what the symptoms of pneumonitis are, which is not just shortness of breath or cough. Unexplained fever is a common one, right?
Absolutely.
And that your nursing staff, your triage team, your APPs, everybody who touches the patient's space understands when to think and think early and scan early.
Right.
So I think that's part of that discussion.
Good. Now, there have been more insights into this sort of induction maintenance paradigm, like Patina, including here at San Antonio. There's the trial using Tucabit.
Yeah, the HER2 climate trial, right?
What's your take on that? Can you see yourself thinking about that?
I do, and I do. And as I was watching the data presented, I found myself scribbling what I was going to do for an ER positive versus an ER negative. And again, I am overwhelmed by the notion of what the progression-free survival for these patients could be if you start to, again, we're now melding, right? We're blending trials and data because we really aren't going to have maintenance data for this paradigm anytime soon, if at all. Hopefully we will at all. Yes, very enthusiastic about it. For example,
Specifically for the hormone receptor negative group?
So the hormone receptor negative group, let's think about that, right? So like tucatinib is a drug that, it's really easy to dose modify if needed if somebody does have, for example, diarrhea or hepatotoxicity, and usually a patient could feel quite well on that. In fact, usually when we use tucatinib and we combine it with capecitabine, the capecitabine is the toxicity driver.
That's true.
And so I don't worry about that. I mean, certainly we have a cost issue. We're layering very expensive drugs on very expensive drugs. So that's one discussion. But you've got a drug that can decrease central nervous system events, is usually going to be able to be used without quality of life deficit and can prolong that maintenance period, that excites me. It does.
Okay.
Yeah.
And what about tolerability? What do you think of the safety on Princeton 505?
I felt very comfortable with that. Again, assuming nobody's pushing the dose. If somebody's having GI toxicity on Ducatin, like you can't ask that of somebody for years when you could bring a dose down.
Right.
I mean, can I ask how you felt about the maintenance data and how you think about it?
Well, I think it might be a consideration for selected patients who may not be candidates for antibody-drug conjugate first-line treatment, that they could consider this as a, induction maintenance strategy for the hormone receptor negative groups. The hormone receptor positive, I think I'm frankly probably more excited about the Patina approach because the synergism between CDK4/6 inhibitors and anti-HER2 agents. So that's kind of my take. But I think for the vast majority of patients, I'm going to be talking about Desiprestone now.
Oh, for sure. For sure.
There's also the Inavo 122 trial, which is induction maintenance with a maintenance of inavolisib for acute ischemia, which we saw 30% in the DB09 trial, as we mentioned. So that's another ongoing strategy that we'll get data from probably next year. What are your kind of final takes then on the induction maintenance versus DB09 with an ADC Pertuzumab doublet up front? And could you envision a future where maybe for selected patients, let's say the hormone receptor positive subset, could you do a DB09 induction followed by a Patina maintenance?
Yeah, and that's
future.
Yeah, and that's what that's exactly what I've been alluding to when I'm talking about melding these paradigms. Yes, I do see that. I see that probably being the way real world use will be quite frequently. However, having said that, many patients tolerate T-DXd very well. And if somebody's doing extremely well, once you started the DB09 regimen, you could also argue why change it. So maybe that's not the patient you're pushing for maintenance on.
I see.
Why rock that boat? So I really think that these are going to be, clearly we agree that Desiprestone regimen is unbelievably exceptional and will be what we prefer to start with. But where the art of taking a patient through those months and years after, I think that's going to be a lot to bear. Yeah.
There's another trial called the Demeter study, which is an induction maintenance strategy with T-DXd for 6 cycles up front. But it's only 6 cycles. Do you think that's enough for a induction strategy, or would you be comfortable with maybe 8 or maybe 2 cycles beyond the best progression, or some empirical?
It's funny because we have no, as far as I'm aware, we do not have data to guide us to say that, and correct me if I'm wrong, that it matters that we get to best response with a number of induction cycles. I haven't seen that. So my practice for many years with Cleopatra has been, if they're not symptomatic from disease and they've showed some sort of great response to the induction, I'll stop at 4, I'll stop at 3 months.
Okay.
And I see no problem with that. And I think the same goes for when you're thinking about T-DXd. Do I feel comfortable with 6 as DB09 did with the taxing? Yeah, I do. Okay. But here's what we don't know. Obviously, we don't know what that progression-free survival is when we do that. But then we also don't know how you might make up for that with the maintenance. And so it's a bit of a mess of data still once you get into that.
So in summary, what are your key takeaways about this first-line HER2-positive metastatic space in, late 2025? Where are we now, and can you speculate perhaps about what's expected in the future?
I think we have a new standard of care.
I think so. Yeah.
I think we all agree on that, and that's exciting. I think that we have a wealth of trial data to tap into to individualized care and to meet patients' goals. Most importantly, talk to them about what they're willing to do. Talk to them about what they're unwilling to experience or subject themselves to, what risks are they not willing to take. So there is that joint conversation, and fortunately, we have options if Desiprestone isn't for them. But I think for the vast majority of patients, that's going to be what we're doing. And I think the questions to come are going to be, 1, how long do we have to, think about infusional therapy versus maintenance therapy? And I should clarify, because often we use the subcutaneous antibodies in maintenance. And then 2, the central nervous system events, this is often talked about, but these are very early events in a good number of these patients, right? And so I'm not quite sure what we're going to see with that, particularly if we're using other maintenance regimens. So that's where we have to sort things out.
Pressing.
Yeah.
Great. Well, thank you so much for taking time out of your busy schedule here at San Antonio to have this discussion. It's been very insightful.
Thank you.
We hope that our discussion today will be very helpful to you in your clinical practice and also especially for your patients. So again, thank you so much. It's been really insightful, and please give us future updates after the next major conference in breast cancer.
Thanks for having me with you.
Thank you so much. Have a great day.
All right. I mean, this feel like you guys said all at once. This is really great.